YouTube.
Yeah.
Preparing for that. I might just take a short pause just because it doesn't catch the first bit. I might just take a short pause. Great. Just because it doesn't catch the first bit. Alhamdulillahi Rabbil Alameen. Salatu wassalamu ala Sayyidina Muhammad wa ala alihi wa ashabihi ajma'een. Assalamu alaikum to everyone. Assalamu alaikum again, everyone, to those who have joined us for this evening's episode of Spiritual Solitude. Alhamdulillah, we are continuing with our theme of coping in difficult times. And this week's topic is managing depression. A very important topic. As we know, the COVID-19 pandemic has resulted and the resulting lockdown are taking a toll on almost every aspect of our lives, including, of course, our own mental health and well-being. And one of the key things that's come out of this is the stresses on the health risk that this pandemic presents, and the tragic loss of life is caused, combined with social isolation, a lack of access to favorite activities, and an uncertain future are taxing for everyone. These issues may be especially challenging for those experiencing mental health conditions. So managing depressions, how do we deal with depression? How do we deal with issues related to psychological impact of the disease? One of the Chinese study that came out said that almost 35% of respondents reported psychological issues due to the pandemic. For those already living with depression, COVID-19 is an additional complication, and vulnerable people who did not have clinical depression before the pandemic may also be expressing symptoms of depression. So alhamdulillah, we are joined again this evening an esteemed speaker, a person who is engaged not in this field only, but also in our communities, and has very good insight into our communities, being the Chief Executive of the Muslim Engagement and Development, MEND, as they are known as, Dr. Shazad Amin, who recently retired as an NHS consultant in adult psychiatry based in Manchester. He works as a court expert witness, mainly in the area of clinical negligence. He's also a chair of the Medical Practitioners Tribunal Service, which makes decisions about a doctor's fitness to practice. So thank you very much, Dr. Shazad Amin, for joining. As you can see, it's a very important subject, and I'm going to hand over to you to give us some insight on managing depression.
Bismillah ar-Rahman ar-Rahim. Jazakallah khairun. Allahumma inni ala dhikrika wa shukrika wa husni ibadatik. I will share my screen with you. I have a presentation to go through for about half an hour. Then hopefully, inshallah, we can take some Q&A. So let me see. Hopefully, can you see my presentation? I'm going to do a slideshow from start. Hussein, can you see my presentation?
Yes, now we can.
Excellent, thank you. Okay, so I'll start. Bismillah. So I call this Muslims the reality of depression, because one of the issues we'll talk about later on is that often Muslims and other kind of ethnic communities don't often take this illness seriously, or certainly as seriously as physical illnesses, and we'll talk about that. So what am I going to talk about generally today is about stress and mental illness generally, the causes of mental disorder and the causes of depression, symptom sign, some Islamic concepts and treatments. I know you had a excellent presentation by Aisha Aslam last week on Sukoon, and she covered some of this area, but there may be some overlap, but I don't think that's such a bad thing. So obviously, looking at the whole area of mental health, there is a very wide spectrum of symptoms, and I think Hussein mentioned some of them at the top of this presentation. During the COVID crisis have certainly increased significantly for lots of reasons I think people will be aware of, and one of them, of course, is depression, is what we're talking about today. But there's a big overlap between kind of stress, worry, anxiety, and a lot of them overlap significantly there. Before I come on to depression, I want to talk a little bit about stress, because it's very important to understand stress and how it affects how we feel and how we perform. Now, this is the classic stress performance curve, which shows, if you start at the bottom left here, if we have a too little stress, that's actually quite bad for us, because it makes us inactive, makes us lazy, and we're quite laid back and we don't do anything. So we need an optimum amount of stress in order to function. And we all know that, for example, when we're studying for exams, if there was no examination, a lot of us wouldn't bother revising. I mean, that's given, isn't it? Yes. So actually that performance can increase if there's a bit of stress to push us. Of course, once we get to past this peak here, that's optimum stress and functioning. If we go past this point, we can start becoming mentally exhausted. And obviously then it has an effect on our physical health. And then coming down this end of the slope here, that's when we can start having serious mental health problems, like depression, anxiety, and some of us might, what we term generally, have a mental breakdown or a serious mental illness. So, and that's the area of burnout, as you can see at the bottom there, really. So there's a whole spectrum of stress that we all go through. We all fluctuate backwards and forwards with this throughout our lives. But I guess the important thing at this point in time is what COVID-19 has done is, for most of us, has shifted this whole curve to the right. So whereas people were operating maybe around here now, some people are being tipped over the curve and are operating around here. And that's what's causing some of the difficulties that we are seeing. Obviously, there's a lot of work already been done on giving people advice. And again, I refer back to the presentation last week you had from Aisha about how do we manage some of our spiritual needs and the overlap. And I'm going to talk a little bit about this later, but I would recommend this document from the British Board of Scholars and Imams about how we manage our mental health, etc. So I do commend that people to read. It was published last month. So let's look at the size of the problem of depression, generally speaking. And one way we can look at it, the WHO, World Health Organization, produces different stats globally. And one of them is called the burden of disease, and it does it kind of every few years. And it produces a top 10 causes, or we call years lived with disability, i.e. what are the illnesses or conditions which cause most disability, as opposed to death and that kind of thing, disability in the world. And we can see, actually, if we put the top 10 up, really, the mental disorders are number 2 on that list, second only to what's known as musculoskeletal disorders. That's basically chronic, like chronic back pain, for example, which are very common. It's actually more significant in terms of disability causes than things like we're more familiar with, like diabetes, for example, or respiratory conditions like asthma. So it's a pretty important area in general. And if we look at the prevalence of depression worldwide, now this is a bit of a busy graph here. I'll just explain it to you. On the left-hand side, we have males, right-hand side, females, study done worldwide about 3 years ago. And we've got, I'm not sure you can read these headings here. These are different countries. So it starts with Mexico, Angola, various countries around the world, USA, Australia at the bottom. So you can see here from the figures, the prevalence per 100,000, i.e. the percentage cases of depression. It's actually very similar. It's around 12 to 17%, regardless of where you are in the world. Now, this is significant because people have this idea that, you know, depression is a very Western concept. You know, only in rich, economically wealthy countries do you get this concept of depression, whereas studies have shown actually that it's something that exists across the world. Obviously, it presents very differently in Indonesia or Mexico or China than it does in maybe in the UK or USA. But essentially, it's something that's a worldwide problem. And there's good evidence to show that. Now, I mentioned before about stress and mental illness and how the two are linked. And it's important to understand this. So all of us have stress in our lives, I mentioned before on the curve, and we can all cope with a bit of stress. But stress leads to mental illness, and especially if several factors come together. So the first thing is basically there are multiple stresses, yeah? So we can cope with one thing at a time, but when we get too many things happening to us, so for example, we've got an exam to revise for, we may have some problems with our spouses or children or whatever, we may be moving house, something else might have happened, we might have, you know, have financial problems, then we get a much more closer link to stress causing mental illness. If the stresses are severe, obviously, basically, missing your favorite TV program is not the same as losing your job, for example, in terms of severity. And timing is important as well. So even severe stresses, if they're spaced apart, months or even years, we can cope with that. If they come one after another, i.e., in a week you get 3 or 4, again, that adds to the stress burden. And finally, the personality of the person is important, because in my time as a psychiatrist, I've seen many patients with depression, and it's quite incredible. You can have 2 people who have the same kind of stresses, and one person basically copes reasonably well, the other person goes to pieces with the same stress. And the difference there may well be that personality of the person. Some people are naturally vulnerable to mental illness, and that's no different to physical health. Some people naturally are more prone to getting coughs and colds and chest infections and things like that. So it's no different to physical health. So a combination of stress and vulnerability can lead to mental illness. And this is called the stress vulnerability model in terms of the psychology and psychiatrist terms. And I can illustrate this more easily visibly, or visually rather. If you look at the left-hand side, this person's capacity is like a glass or a cup. And we look at vulnerability and stress in the blue and black areas. If we start with 2 people of different vulnerability, this person is more vulnerable. It has a higher vulnerability level. And we give these 2 people the same amount of stress and add it to these 2 containers, we can see clearly that the person on the right can absorb that stress because of their personality, whereas the person on left, it overflows the cup, meaning that person has a breakdown or a severe mental illness. Yeah, so that's how the interaction works between stress and vulnerability in people's personality. Now let's look at the common causes of mental illness. I mean, not just in Muslim communities, but I'm looking obviously our community here primarily, other communities as well, and we can group them in different categories. So social stresses, psychological, physical, and we call paranormal or even spiritual in some places. So people will be well aware social stresses, for example, already talked about relationships and finances and work and things like that. Life events are well known, basically things like divorce, losing your job. Drugs and alcohol, very common, especially in young people. People might think, well, as Muslims, we don't suffer from that problem. You would be mistaken. The problem is much more hidden, and there's a lot of stigma attached to admitting it, but it certainly is a problem. And especially now, drugs in young people, shisha, for example, cannabis, and things like that. And of course, relationships I've already mentioned are important. Psychological stresses I've already mentioned, personality. There's also something called thinking styles. And some people naturally have a certain way of thinking, which makes them more prone. So we all know people who tend to look on the negative side of everything. Yeah, we all know people, some people are naturally optimistic and positive. Some people are naturally pessimistic and negative. And that negative thinking sometimes can lead to people being more prone to mental illness and depression. And of course, people have different coping mechanisms, and we all have different ways of coping, as some are better than others. In terms of physical illnesses, we know there's a genetic link with depression. So for example, you're much more likely to have a depressive illness if your close family member, we use the term here, first degree relative, which basically means either one of your parents, your siblings, or your children has had depression. We know there are certain medical conditions that predispose you. So for example, chronic conditions, any chronic illness like depression, arthritis, and asthma, things like that. Also painful conditions, people in chronic pain, like having severe arthritis, for example, can also predispose you. And a very important one, people sometimes forget, childbirth, yeah? Your chances of developing a mental illness, certainly obviously for ladies, goes through the roof, is sky high shortly after giving a birth to a child for lots of reasons, but postnatal depression, we call it, it can be quite a devastating, severe illness at that time. And in terms of paranormal, things like obviously jinn possession, evil eye, black magic, I'm not going to talk too much about that, because obviously that's a separate different talk, but jinn possession certainly is a very common belief in our communities causing depression, and I will talk about that a little bit later on in this presentation. So that's kind of a spectrum of what causes depression in different categories. The next thing to talk about is that the word depression can mean a lot of different things. Yeah. Now, obviously, there's a spectrum here, and I've shown the kind of spectrum that we tend to use in terms of terminology as psychiatrists or psychologists. So we go from people naturally feeling distressed. Yeah. So something bad happens, you feel upset, distressed. That's not an illness in itself, of course. That's a natural human reaction. Then we have something a bit more severe, we call it adjustment disorder. So people are adjusting to a new thing. So for example, adjusting to, well, like for example, COVID, people being put on furlough or losing their jobs, which is a massive stressor. They may have lots of symptoms like worry, not sleeping, depression, all of that kind of thing, yeah? And then we move up the ladder, and certainly from a psychiatric perspective, we categorize depressive illness into 3 areas: mild, moderate, and depression. And I'm going to show you there's a big difference between severe depression and the mild end of the spectrum, adjustment disorder, mild end down here. But that the spectrum is important. And here, I'm going to talk about here feeling depressed versus a depressive illness, yeah? So when we're stressed, what happens? Well, we might feel down for a few days, i.e. it's temporary. We might feel a bit anxious, we feel worried, we're not sleeping, but that tends to be a transient thing. In a depressive illness, we're feeling down constantly, i.e. it doesn't go away, yeah? It doesn't change throughout the day, and it doesn't change day on day. It's exactly the same. We might feel hopeless, not just a bit anxious, just generally hopeless about the future. We might start feeling guilty about feeling that way and letting people down. The fact that we can't go to work or we can't look after our children and you know, have the same kind of relationships. And of course, that can progress to people feeling suicidal. And I'm going to talk a bit more about that later on, because that has a certain particular significance in Islam and how we view it. And then it's also physical symptoms like loss of appetite and loss of weight and things like that. And finally, also loss of interest. We kind of lose interest in the things that we normally would like to, whether that's kind of, you know, playing with the children or watching TV or reading and things like that. And the other final thing is we start to avoid other people. Yeah, people who are depressed don't like interacting because they don't want people to see them in this state. So often you'll find people not replying to messages on WhatsApp, not returning calls and things like that. So there's a big difference between just a bit of stress and then a depressive illness. And the other thing I want to show is that people think of depression as a mental problem, but actually it's a very physical problem as well. So in addition to the psychological symptoms on the left-hand side, if you look at the red symptoms there and the physical, you can see that actually these are quite serious. Yeah, people have difficulty eating, they lose weight, they haven't got any energy to do anything, and people often get labeled as lazy. You know, people can't get out of bed, well, you're just being lazy kind of thing, you know, and get told to pull yourself together kind of thing. And often they have specific sleep problems. Like, for example, they wake up early in the morning when they're way before their time and they can't get back to sleep. And it's important because the first time that someone is aware that they are depressed, maybe somebody comments that, hey, you're not looking the same as you were. You know, have you lost weight? You're not looking well, you know, physically, because they may not realize these symptoms on the left-hand side. Because they're in the middle of depression, they don't realize some of these things are happening to them. Whereas somebody commenting on their physical appearance may be the first time they realize something is not right. Just touching on a few Islamic aspects. Again, I should preface this by saying I'm not a scholar, so I don't have, you know, that degree of Islamic knowledge, but obviously I'm Muslim. I have a lot of experience dealing with patients over the years, and some of them obviously have been Muslim. And there are some Islamic aspects I want to comment on. The first is, you know, I think you touched on this last week, Hussein, with your guest, Aisha, about people going to see imams. And obviously, it depends on what kind of imam you go to, whether that person has some understanding of psychology, psychiatry, etc. Not all of them do, to be fair. But some that don't will often tell people that depression is caused by weak iman. Yeah. And what you need to do is read more Quran, increase your nafil prayers and things like that, which really, for people who are severely depressed, isn't helpful at all. Because A, they're not going to be able to do that, and B, to be told that when they are ill actually makes them feel guilty. And it actually makes the depression worse. So you go to an imam to actually get some help and feel better, and you come away possibly feeling worse. So that's something to bear in mind. And with that, of course, a loss of faith in general is something we're told. But of course, if you remember that in severe depression, people lose interest in things as a symptom of depression. So somebody who's religious and severely depressed may lose interest in actually reading the Quran or keeping up with their prayers, or may not physically be able to. We talked about, sleep disturbance and things, and people getting up Fajr in the summer months at 3 or 4 in the morning. They're not going to be able to do that sometimes. So actually that really, again, doesn't help at all. And exactly. And then again, that gets interpreted as people being lazy and having a weak iman. Clearly, shaitan has been whispering to you, your iman is weak now, it's low. You've got to increase your taqwa and your Quran. And that isn't, people aren't able to do that. So it's a vicious cycle they get into, which actually makes them worse. Then, of course, we have the big one. When people confide in someone, say, look, I'm having suicidal thoughts kind of thing, that can also be viewed as very negative. And, obviously, there's a specific taboo in our culture and our religion as well. I want to talk a little bit about that. Now, in terms of where that comes from, we know there are a verse in the Quran talking about this in terms of, suicide. So Surah Nisa and Surah Baqarah as well talk about it, not directly, but I think the scholars have interpreted this to be a reference to suicide. So clearly suicide is forbidden in Islam, but actually you have to look beyond that the headline statement. What we are assuming there is the person has the ability or the capacity to make a choice, i.e. they're not simply choosing an easy way out as opposed to turning to Allah and actually increasing their religious activities. So there's an important distinction there that to be made. And when we hear about people who committed suicide, we've got to bear this in mind. And I've had discussions with scholars about this as well. So you have to know whether the person has we call capacity. So for example, somebody who's severely depressed, someone who's in chronic pain, who is not depressed, let's say they just have terminal cancer or something like that, they may have the capacity to decide, you know what, I've had enough, basically, I don't like my quality of life, I'm going to kind of kill myself. Now, that's exactly what would be basically viewed negatively in Islam. However, if they've got a severe depression, they may not have capacity. In fact, they may be so severely depressed, they actually lose the ability to reason, yeah? So basically, the same way somebody who is basically deemed to be insane is relieved of the burden to pray, there is no obligation to pray on the person who doesn't have the capacity to be able to pray. In the same way, in severe depression, somebody may believe, for example, falsely, they've got an incurable illness, for example, yeah, or they may have severe suicidal thoughts as part of their depression. So therefore, I think it's only a major sin if the intention was to kill oneself with capacity. And the problem there, of course, is this, that if you hear about a brother or sister in the community who has killed themselves and, you're asked to go to a janazah, how do you know what their intention was? Yes, it's very difficult to actually, unless you know that person very well, you don't know what they intended, unless, of course, there's a coroner's inquest that happens 6 months later, way after the janazah. So it's very difficult to do that, really. And of course, Prophet ﷺ here didn't pray janazah prayer for a man who committed suicide, but he ordered his companions to do so. So here, there's a distinction here between the leadership of a community, basically praying the janazah prayer to actually signal to the community that this is not an okay act, in a certain context. But of course, praying, you shouldn't then all therefore by that act mean that no one should go to a janazah prayer for somebody who's committed suicide. So I think that's a very nuanced area, and people need to reflect on this a little bit more rather than simply saying suicide is a sin, end of, really. And again, I've mentioned the intention is difficult to judge. Anyway, that's enough of the description of depression. More importantly, let's look at some solutions or how we tackle this particular illness. Now, the first thing I want to mention, again, this was briefly mentioned last week as well, I think, is stigma, which is a massive issue in our community. Now, stigma comes from the Greek word stigmatum, which means a mark. And therefore, people with mental illness and depression specifically sometimes are marked out negatively. And basically, they are often used to denote negative attitudes to mental illness and the mentally ill, yeah? And of course, this is a widespread problem. I'm not suggesting for a minute. It's simply in Muslim societies. It's a widespread problem in all societies. But we have a specific problem, certainly in the South Asian and Muslim communities that I'm from, as we'll come on to. Stigma itself has three parts to it. We have a lack of knowledge, which leads to ignorance. We have negative attitudes leading to prejudice. And then we have behavior that leads to discrimination. So there are different levels of it. And we'll go through each one. So lack of knowledge. So what kind of things? As people have all sorts of misconceptions about mentally people are violent as a broad term kind of thing. Yeah, something that's pushed by the media, as we'll see in a minute kind of thing. Or they're just lazy. Yeah, I've mentioned if you're depressed, you can't, you're not bothering to get out of bed. You haven't combed your hair. You haven't dressed yourself. They are labeled as lazy rather than ill. They never recover. Mental illness seems some kind of like death warrant. Once you become depressed or given a mental label, you can never get better, which is completely false. In fact, the vast majority of people have an episode of illness and get better, just like you would if you have basically a chest infection or a bout of food poisoning. Again, due to a weak personality, it's not, obviously people are vulnerable in different ways, but that doesn't mean that you're weak as a pejorative term, because it can affect everybody. And it's not like a physical illness kind of thing. And I'm going to come on to that a little bit later, but generally speaking, it isn't accorded the same respect as physical illness is. And here's a study done a few years ago, again, different countries. People ask the question, people who thinks mental illness is similar to physical illness in the sense of, its importance. And you can see there's a bit of a variation here in countries more, I guess, third world, Pakistan, Algeria, Morocco, versus the more Western developed world. Slightly more people think it's similar and slightly less so in those countries I mentioned before, which means, of course, it's treated very differently. And you tend to find that mental health services are a bit more advanced in these countries at the bottom versus the countries at the top, generally speaking, really. Moving on to negative attitudes, these are, of course, linked to ignorance. I mentioned ignorance and stereotypes as a belief that people who share a characteristic are all the same. And they're useful since they reinforce stereotypes that, us versus them kind of thing, really, and that our worldview is correct. And this is a study done several years ago, kind of a community survey, attitudes of mental illness. And it found actually that in Asians versus white or black other groups, that knowledge about mental illness was lower and negative attitudes were higher. Some evidence there that certainly Asians and South Asians, have more of a problem in this area than maybe the white and other ethnic communities. And again, a specific study done in Northwest London a few years back in Harrow, and looking at different views about how it was, how people thought about mental illness, and different views came out there. Mental illness, punishment from Allah, we just accept it as qadr, which is interesting, isn't it? Because you would never accept having a heart attack as qadr, would you? You wouldn't say, well, I'm having chest pain, that's qadr, basically. I'm not going to go to casualty or treat myself. That would be ridiculous. So again, a very different way that mental illness is viewed. A lot of issues about shame, social standing, this concept of izzat in our communities. And of course, for young women, a big issue about marital prospects. People hiding the fact that people have had mental health problems because people will view that negatively, and that will affect their chances of getting a rishta or their marital prospects. And of course, jinn possession is a very big common belief, really, in our communities. Maybe we can touch on that in the Q&A a bit more. But actually, looking at this area, the vast majority of illnesses are not due to jinn possession at all, but it's a common belief that we have to think about and challenge, really. And finally, people didn't think they could be helped, so didn't bother seeking help, which is very sad. And that is quite common as well, really. And one of the problems we have is language. Of course, we have a lot of terms we use for people which are very negative, which you don't use for physical illness, yeah? So there's another reason why people don't come forward and feel stigmatized. And I mentioned violence there. We have headlines like this, 1,200 patients, 12 people kill mental health patients. You think, my goodness, there's an epidemic out there of people who are mentally ill going around killing people, which is not the case at all. This is over 10 years. And what it doesn't tell you, of course, is that the vast majority of people are not killed by people with mental illness at all. But they are reported in the media in this way. And finally, just briefly, discrimination kind of thing. And what's sad is most patients in this survey experience discrimination. And in half cases, nearly from family and friends, people closest to you, often that makes it even more difficult. How do you get support when the people closest to you have these attitudes? How do we deal with stress and mild depression? Well, there's positive ways of talking about it. Again, your guest last week, I think, talked about some of this. There are alternative treatments, acupuncture, meditation, yoga. Of course, that overlaps with sadhana, and mindfulness is a big thing in recent years. You cannot underestimate the importance of a balanced diet, good exercise, and sleep. People don't give much attention to this. And one of my other talks, I talk about the issue of sleep has been completely transformed in the era of mobile phones, because we're constantly connected 24/7 to our phones. This has actually destroyed people's sleep patterns and caused no end of stress and added to people's depression. And then what's happened here? Sorry, my screen's stuck. Just bear with me. I'm just going to stop sharing. I can't do that either. Oh, hold on. Oh, I've lost my mouse. So hold on. Just bear with me. I was saying, can you just take back control of the screen? I'm just going to try and come out and go log back in, because I can't get a response from my PowerPoint. Thank you. Let me just, so apologies if I can. We'll have to edit this bit out, won't we? Yeah, no, I've not got my mouse working. Let me just. Oh, it's I've got the dreaded colored circle, so I'm going to have to do a force quit and log back into PowerPoint. I think, yeah, it's frozen. Sorry about this. I'm going to force quit PowerPoint. I'm trying to find my presentation again. Just give me 1 minute, it's loading up. Right. Okay, it's loading up now. Let me find where I was. Where was I? Yes, I've got it. Okay, slideshow, current slide. So, can you see this now? Oh no, am I sharing screen? Let me just do that first. Share screen. Yeah, got it now. Yeah. Right. Can you see this now? Can you see this?
Yeah, if you could put it on, that's it. That's great.
Excellent. Yeah. Sorry. Yeah. Sorry. Sleep is a big problem as well. And the other concept I want to talk about is shukr and sabr. I'll come on to these concepts in a minute from an Islamic point of view. From a negative side, people cope with it very differently sometimes. They keep everything inside them, which makes things worse. They don't talk about it. They isolate themselves, very difficult. They take it out on other people. People get angry and lash out, and that's often, and of course, then people turn to alcohol and drugs and things like that, which obviously doesn't help either, really. Two concepts which we need to think about, certainly in mild depression, as Muslims, is obviously someone is a response to trials and tribulations, and we know what it is, and many Quranic examples I won't go into of that, really. And obviously in Surah Nisa, Allah Ta'ala tells us that we will be tested and we will have difficulties that we will have to overcome. And again, I'm talking about mild depression here. And one of the ways, interesting things about sabr is actually, it's very important as a personality characteristic. Now, this strange slide here shows, is meant to depict something called the marshmallow test. And the marshmallow test was an experiment done in the 1970s by a psychologist called Walter Mischel. And what he did was took a group of 5 to 47-year-olds and he put them in a room and he gave them and basically a plate with a marshmallow in it. And he said to the children, look, you've got a choice now. You can either have this marshmallow now, or I'm going to leave the room. And if you can wait 10 minutes, you'll get a whole plate full. And then they videoed these children and they wanted to know which ones ate the marshmallow straight away, which ones had sabr and waited for the whole plateful in 10 minutes time. So there's a study of what we call delayed gratification. And what was really interesting is they followed up these children 10, 15 years later when they were adults. And they found the children who originally could resist the marshmallow had much better outcomes in terms of school results, health, incomes, jobs, and things like that, really, which was really interesting. Show it's something that has predictive value in this world as well. And of course, in shukr, I'm not going to go into this saying Ibn Abbas too much, really. But of course, we need to have shukr as well. We're faced with tribulations in terms of, well, it could have been worse. And obviously, whatever's happening to us is happening in this world and not the next. Now, in terms of treating with medication, obviously, we can find some things over the counter. So, for example, something called St. John's wort is a herbal preparation. It's licensed for mild depression, and not in this country, in some countries, but people can still get it. And there is some evidence that it has some efficacy in mild depression. We can get prescribed medications from our GP, antidepressants, anti-anxiety. And again, I'm happy to talk about these later, which obviously help people with more severe depression. I'm not going to talk about this as some magnetic stimulation. It's just new treatment out. But people might have heard something called ECT, electroconvulsive therapy. Some people have it. I mean, it's a bizarre treatment. People having electrodes and a small electric current as a treatment for depression, but it does work for severe depression. It's something that sounds quite scary, but it's something that does have a good efficacy. And then finally, I'm going to touch on, I think you covered this last week with your guest, counseling and therapy. Now, there's a big difference here between counseling and therapy. Counseling is for mild depression, short-term specific. Therapy is much more long-term and more severe. So I guess the difference between those two is a bit like, if I give the analogy, and counseling is a bit like helping someone dealing with a wound with a sticking plaster, and therapy is as having surgery itself. So different levels, really, yeah. And then at the bottom here, different types of therapies, lots of different types. I don't want to go into them. CBT, cognitive behavior therapy is the common one, but there's no time, I think, to discuss them here. So broadly speaking, that's the kind of things that you could do about it. But the important thing is there is treatment available. People think, well, what's the point? I'm not going to get any help, or treatment that's not going to be effective. Certainly, sometimes a combination of support, counseling, medication, all of those things can be very, very effective. And of course, I think you had the lady from Sukoon here. There are lots of now different organizations specifically tailored toward the Muslim community, which can help now. So Muslim Youth Helpline, for example, Sukoon you had on last week, British Islamic Medical Association, so and different ones which are out there, which can help us in different aspects. And basically, they certainly in the pandemic, they've certainly reached out to people. Obviously, it's more difficult, people who are in lockdown and isolation, to get help. So in conclusion, I just want to mention a few things. Mental illness is very common. Depression is common. Combination of stress and vulnerability. Stigma is a major problem. There is help and treatments available out there. And I think I'll leave it there, and I will stop sharing and hand back over to Hussein. Thank you very much for that.
Thank you very much, Dr. Shazad Amin, for that. That was very comprehensive, and within a time that you've covered so much, there's so much to cover there. I've already got a couple of questions that I wanted to ask you. One of them you referred to was the use of language.
Yeah.
The way that we refer to a person with mental health, even with depression in the topic that we're discussing today. I have heard in it use the word insane, crazy, even used in a fit class. Oh, if somebody goes crazy, yeah, they don't have to pray, or they don't have to fast, or something like that. What can we do? And I know you're involved at kind of a nationwide level, even within the Muslim community, with British medical health and so on. How can we educate, especially our ulama, and those who are teaching about the kind of language that perhaps, we, or is there some sort of understanding that we could say, look, this is a really good way to describe those, even within the way you teach your fiqh, your Islamic.
A very good question. I think, to be fair, it's not just the ulama, it's society in general. So we can't necessarily say it's just the ulama. These terms are used colloquially, yeah? And I guess there is a slight distinction to be made between terms which have a broader or multiple meanings. So, for example, if I say something's insane, I mean it's incredible. Yes, I don't mean it in a minute. So there are some words which have dual meanings, yeah, which can obviously, I think that there's some scope there. You can't stop everyone using those terms. I think where the particular problem is when it's used negatively, pejoratively. So basically, stop acting in a crazy way, or that one's crazy, ignore him, kind of thing, yeah? It's just a question of education. I think we've all got to educate ourselves and understanding. First, it's all about education, understanding what mental illness actually is, because obviously there's a lot of ignorance out there about the mental illness itself, first of all. And of course, then we tend to be quite lazy and use these terms generically to indicate people who we don't like. The guy's a bit crazy, leave him, yeah, or whatever. And that then obviously gets incorporated into our natural language, and actually filters down to people who've then got mental health problems. They are less likely to come to you if they think you are likely to not take them seriously or likely to laugh at them. It's very interesting. I tend to fit class, and with our sheikh, and I sit right in front of the sheikh giving the class, and he looks at me and he stops himself sometimes using those terms after he makes eye contact with me. So, as a very minor example, obviously, yeah, but it's about educating people, and then people are mindful, and people usually can find a different way and use a different term, but it's going to be a slow process, this. I think, we all have a responsibility just to be mindful of how we speak about this topic.
Yeah, I didn't mean to indicate that that the ulama are the only ones.
Oh no, not at all.
I think it's really important right from the top in terms of the religious community.
No, but it's important. I think the ulama are often the first port of contact. That's why it's important to mention them. Yeah, absolutely. So if you're the first person that person has contact with, you have an extra responsibility, in a sense, to make sure that person feels comfortable in discussing their problems. Absolutely.
I've got a question here from Jahera Ali, who's asking, Salam, can people develop their resilience to be less vulnerable to depression?
To an extent. Obviously, there are some stresses that we can avoid, and some. So, for example, you can choose not to take drugs or take alcohol and things like that, or put yourself in situations, which you can foresee. Of course, not everything can be foreseen. Things happen to us which we're not in control of, and you can't do anything about that. And of course, then we can't change things like genetics. We can't choose our parents, for example. Yes. So I think it depends upon what we can control and change and what we can't. So I think the answer then depends on whether a person can recognize, are there stresses that I can avoid? Do I have a family history? Am I more prone to getting this illness because my father had it, or my mother got it when she gave birth to me, or something like that? In some cases, yes, the answer is yes, and you can. But in other cases, you can't. So I think it varies from person to person.
The next question that I have is, how do you deal with somebody who is in denial? Some of the things you're describing, I can see that in somebody, but this person is in denial. How do you deal with that kind of?
Excellent question. And often it's a common problem. First of all, we've got to understand why the denial is there. Why do people deny mental illness? Because obviously, if you look at physical illness, very few people will deny they've had a heart attack or having chest pain. It's not something that's often seen on the physical side. So the reason for the denial, first of all, is often comes down to what I was talking about before. It's about stigma and shame. Yeah. Because then obviously if you can deny it, and the denial is actually an internal mechanism which we all use to, in a sense, repress sometimes negative things. Yeah. We've almost kind of forgotten it internally that we don't have to deal with it. Or if it is conscious, and denial can be conscious as well, we don't want to talk about our problems because of the reaction we will get from people. So if you talk about something and you think the person's going to laugh at you or make fun of you or ridicule you or have some kind of negative reaction, why would you want to? You have to then find someone you're comfortable with. So in a sense, the person then dealing with that person needs to find a form of language and a form of words in which they can engage that person. So say, look, it may put something out there like, for example, you're not looking yourself, for example. It must be difficult holding all that in. Or, sometimes, people make fun of people who are depressed. Is that something you're worried about? You approach it in a sensitive manner and you allow the person to attentively test the water. And they might say, yeah, I've been feeling a bit like that. And then that's a way in for you. And then you can, go in kind of thing. Yeah. It's interesting, when I used to do my NHS clinics and my new patients, I would know virtually 99% of them hadn't slept the night before. Yeah. Because coming to see someone like me, for me, it's a day job. Yeah. It's not a big deal. But for them to go and see a psychiatrist is a very big deal because they're worrying about what will he say? Will he label me as mad? Is he going to admit me to an asylum? Is he going to throw away the key? What will people think? All of that. So right at the top, I told them, look, I know you haven't slept. Yeah, I know you're worried about. I would deal with all their worries right from the start. So basically, we would then feel comfortable. And only then would I start asking them how they felt. Because there's no point beforehand doing that. Because until someone feels comfortable with you, you can spend hours with them talking about the weather and everything else. They won't open up to you because that engagement isn't there. So obviously it's more difficult if you're a layperson, but there are techniques like that you can use in a sensitive way to be able to. The other thing I find often in our communities as well is that people don't respect confidentiality, yeah, and sensitivity. So you ask someone in a group of in front of the whole family, what are they going to say? Yeah, and they don't want everyone else to know. So you've got to look at things like where in what environment are you speaking to someone? Is it the right time? Is it the right place? Is the situation conducive to you having that sensitive, if you've got 4 kids running around the room kind of thing, yeah, causing chaos, that's not the right time and place to have a chat to someone about depression. So I think you just got to use some common sense and use some of these techniques to try and break that initial ice, as it were, with someone who's in denial.
The other question I had, you touched on it a little bit on the issue of stigma.
Yeah.
All of those kind of things also refer to a situation where people feel they will be judged.
Yes.
And how do you deal with this? Because it kind of refers to what you were saying about people being in denial, but as well as actually getting the help that they need. So, I've had people where, you can see this is a person who should have actually sought help earlier.
Yes.
But often what you find that people are afraid of being judged.
Yeah.
They're probably absolutely fine otherwise because they're getting on with their daily life. But there are issues of depression, issues of mental health.
Yeah.
And how, especially as a faith community,
yeah,
we are supposed to be a community of mercy, of rahmah,
absolutely,
of following the Prophet ﷺ, who showed us how to deal with people of all types, all in its diversity, from the most disabled person. Even you have Surah Abasa being revealed, so don't even ignore this blind man. So when you get all of that, and then you have a community who are very judgmental when it comes to these things, how do you deal with that? Both are, again, I could go back to right to the top, the leadership level, but as well as at the society level, especially the faith community. We're supposed to be providing a role model when it comes to even these things. What do you think is to go about creating that more awareness so people do feel more comfortable to come forward and it could be tackled head on?
Well, the first thing is right now, you're doing this now with your platform. You're educating people, aren't you? And you're offering a platform to people to see that it's okay to talk about these things. Yeah. So one of the problems before was, well, still is to an extent, certainly in communities and families, is that no one talks about it. And of course, if it's not talked about in something that's hidden, it's naturally something to be shameful of, because of course we only hide things that we're embarrassed about. or we feel ashamed about. So the first thing in tackling that is obviously educating people. And then obviously if you're dealing one-to-one with someone, the most important thing is you have to show that person as a role model that you're not judgmental. Yes. So you need to almost say explicitly, look, whatever it is, I'm not going to judge you for it. Okay. These things happen, it's common. And you might want to say, oh, it's happened to me or whatever kind of thing, to get that person to open up initially. Because once they see the reaction from you is positive, they're going to find it easier to telling the second person. Or it may be, let's go and see a counselor, or let's go and see a psychiatrist, or the imam, or an elder in the family, or a family group community leader, something like that. Because once they've made that first disclosure, making the second one is going to be much easier, but only if they receive a non-judgmental response in the first time. So you're crucial to it. If you're the person who's in the front line dealing with this, and a family member or friend, your reaction is going to set the scene for how that person then views other people as well, really. Yeah. So I think it comes down to education, and as I say, remembering who we are, certainly as from Muslims. And I remind you, mentioned the Prophet ﷺ, reminds me of a story, and I'll paraphrase it, that he was walking with his Sahaba, and he came across a boy who was crying, and he asked the boy why he was crying. He said, my pet bird has died. And he spent some time consoling this boy who was crying. Now, this is Amir al-Mu'mineen. Imagine the prime minister with all the things he has to do, stopping by in the street, sitting down with someone and counseling them. And the Sahaba were looking at him, what are you doing? But he regarded his role at that point in time was to console that boy, something that would be regarded as trivial to most people. So what? It's a kid basically lost his bird, big deal. But for that boy, that bird was everything to him. And the Prophet, with his rahmah, recognized that. So that's a nice example of things that we don't feel are important, because obviously we're all busy, yeah? And when we recognize somebody in distress, we're all guilty, and myself as well, we're all guilty of just running around doing this, that, and the other. Sometimes we don't stop and see someone who is suffering or is close to us or whatever, who needs that time and space. And as you say, as Muslims, we should have the Prophet ﷺ as our role model, and we should be super sensitive to these things rather than the other way around.
Allah. This one is slightly medical question, but it comes up in the context of depression a lot, so I'll ask it as my final question. Is to take or not to take antidepressants?
How long have you got?
But it is a question that plays into people's minds. I've just had, in fact, even on a personal level, I've had a couple in the last week, in fact, saying, look, I've been prescribed antidepressants. Should I be taking it? I have no idea, by the way, I've even asked this question. I'm not even a medical doctor, but I'm probably not the only one, perhaps in the capacity that we're in teaching and doing this sort of thing.
Very good question.
Perhaps we might have an answer.
No, I do. No, absolutely. I'm just going to say, it's going to take a few minutes though, because it's a very simple question, quite a complex answer. So if you'll just indulge me for a few minutes then. So the question of taking it, first of all, we have to understand for what problem is the antidepressant being prescribed for. So you recall the reason I showed that slide before of that spectrum, those steps, is important, because at the bottom of that spectrum, whether it's the milder end of the depression, the adjustment disorder, the distress, antidepressants aren't going to do anything for that. So if I give you my example, over many, many years working as a psychiatrist, I've had people referred to me by GPs who are already on antidepressants, and they're not working, and the GP will refer someone saying, so-and-so has taken X, Y, Z, they're not getting better. Please, can you give me an opinion as to what's going on, what you recommend, And I sit with them and our new patients about an hour for a proper assessment, and you sit with them, you hear their life story, and it's quite apparent to me that that person doesn't have a clinical depression. That person has a very sad life. They may have had a lot of stresses, bad things might be happening to them, but they're not mentally ill. And that distinction isn't easy sometimes to make, but you've got to make that call. So you've got to first of all find someone who can diagnose you accurately. Because in those cases, I told the person, you know what, because they come to me expecting me to prescribe a magic tablet, a new antidepressant, or a higher dose. And I disappointed them and said, look, I'm afraid medication isn't the answer to your problems. You need to change jobs, stop drinking, take time out to do this, all the other things that I might think is important for that person. But the medication wasn't the important thing. And sadly, in our society, not just in Muslim communities now, in our society, certainly over the past 20, 30 years, communities have become more fragmented. You know, families don't stay with each other more. Our support systems are much less. And when we have problems, whereas 30, 40 years ago, even in this country, 50 years ago, people lived in villages, yeah? If you had a problem, your grandparents were living with you, you'd go to the local vicar who knew you first name terms, even the local baker knew you, and everyone knew your problem and people could help you and support you. Nowadays, we don't know who our neighbors are, yeah? It's this truth, isn't it, yes? So who do you go to if you've got a problem? Well, if you've got a problem and you're feeling that way, naturally, the first port of call often is your GP. And I'm not having a go at GPs here because they're very busy people. If you go to your GP, what do you get? You get 5-10 minutes, yeah, of their time. How easy is it to diagnose all of that, listen to someone's life story and prescribe a management plan in 5-10 minutes? Very difficult. Because what often happens is people, you know, they'll hear part of the story. Yeah, I get that. You're upset, you're distressed, you're crying, you're not sleeping, you know, feel, here's a prescription to end the consultation. And then you go away thinking your problem is now going to be solved by the antidepressant because the GP said so. So you are conditioned now to feel your problems are now going to be solved by a tablet, whereas what you need is to deal with the other issues in your life, yeah, in some cases. So first of all, is it actually an illness? Yeah. And often you find there are cases which are not a depressive illness, and you need to solve your difficulties in a different way, like all the other things I mentioned before are important. If it is a more severe illness, depression, then of course antidepressants, you know, they are proper medications. You know, you wouldn't say, well, I had a heart attack, do I take medication now for chest pain or angina? Of course, you know, it's something that has been shown to be effective. They're not effective in all cases, but in over half the cases people take them, they are effective. Now, of course, the choice to take them is down to the patient, yeah? And like all medications, they come with risks. So there are side effects with antidepressants like there are with all tablets. So they might make you feel sick, they might make you put on weight kind of thing, they might make you feel sleepy, and all of these different types of side. And you've got to have that consultation with the GP and then make a decision. Is this the way I want to go? But that's no different to other discussions about medication, because obviously whether you take medication for your arthritis, painkillers, for example, depends on, well, how severe is the problem? Can I cope with the side effects? Can I live without it? And you might find that even people with depressive illness prefer, I mean, a lot of people often say, I don't want to be addicted, I don't want to get on medication that messes with my brain. I'd rather have therapy and counseling. And that's fine. That's an alternative which is as effective in some cases. So it depends on the individual. So I can't give a blanket yes or no, but it's something to consider if you've been properly diagnosed by somebody who generally has taken a proper history and examination, and they say you have a depressive illness that needs treating.
Okay, thank you very much, Dr. Shazad. I mean, it's been really refreshing, and I'm going to have to go over this video again and just listen to some of these things again. And I hope all of our viewers, those of you who are joined after this session, you'll definitely go over the whole video and get a good presentation. And I think one of the things that's come out of this is to really raise that awareness in our communities, in the society at large, not only particularly Muslim community or faith-based communities, but actually this kind of issue is something that needs to be raised awareness across our societies. So thanks again, Dr. Shazad, and join us again in the next session and the final session in this series on coping in difficult times. We're going to be covering ways to well-being, the Islamic perspective, inshallah. So join us again next Wednesday, 7 o'clock. We'll leave you with the thought that Dr. Shazad, was the main theme really that came out is about the prophetic art of listening and really giving that stress on people's well-being and looking out for others, which is something that we've learned over this period of lockdown across society. So Jazakallah khair again. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum salam wa rahmatullahi wa barakatuh.